Good morning. Welcome to Seinfeld. This morning's discussion will focus on the episode, the Bris. So to kick things off, anybody have any thoughts of where they would like to start? Particular character, particular scene? What comes first? And again, remember, in choosing our starting point, never think like a psychiatrist. This has nothing to do with psychiatry or psychology. What did you see that you want to talk about? Keep it fun. What scene or character struck you in the Bris?
I think more than anything, the Moyle seemed to me the least predictable and like the strangest behaving character.
So
I'm curious what you think about the Moyle. Yeah.
Focused on the Moyle. Again, this is a question that's to the entire group. Certainly, there was significant behavior that was demonstrated here. To the group, what did you actually see? I mean, if the Moyle was in your ambulatory care office and behaved the way he did for a 30 or 35-minute follow-up, and you left that office to go into a central room where your attending physician was sitting to hear your report, how would you explain what just transpired over the prior 30 minutes? Anyone?
Unprofessional.
I'm sorry, a little louder.
Unprofessional.
So you felt that he was unprofessional, right? So you had concerns that whatever the behavior was appeared to adversely affect his job performance, right? So certainly deficits in occupational functioning. Trying to draw the wording directly from the DSM. Sure. Okay. So again, whatever was observed, I could say that quickly. We might think it be clinically significant from that perspective. Sure. What was actually observed? You know, when in medicine, you see a patient that your attending physician has not yet seen, your presentation has to really build a mental image of your experience so that your attending understands what was going on, similar to if they were there themselves. Now, of course, after you create that mental image and then present your facts, your findings, the attending is going to go back into the room with you. But what they're walking into should seem familiar to them, right? That's the general practice of medicine in a teaching hospital. As part of that, medical students are required to perform a mental status exam. This is a multifaceted exam that is usually remembered, that is, the different domains or components are usually remembered by the acronym ABC stamp letter. ABC stands for appearance, behavior, and cooperation. And the ABCs in psychiatry really go a long way toward painting that very mental image: appearance, behavior, and cooperation. Can somebody tell me the ABCs of the Moyle?
I mean, his appearance seemed normal. He seemed like well groomed and dressed professionally. I would say his behavior was agitated, dramatic, and reactive. And I think his appearance, behavior. Remind me the C.
Cooperation.
Cooperation. I think he was reluctantly cooperative.
That's fair. All right, so now again, we're now a long way towards my getting an understanding of what your previous 30 minutes may have been like. And think through this. With regard to those ABCs, the next step would be presenting stamp liquor. That is the other components, the rest of the MSC. Intuitively, you can now recognize that you can get those findings for the Moyle and compare them to the very same findings of another character with different ABCs. And you can respect and appreciate how walking into one room could be vastly different than walking into the other room, right? So same exact clinical findings, stamp liquor, but in two separate settings that are painted by the proverbial ABCs. Very important to create that mental image with regard to what your attending physician is literally walking into when they accompany you back into the patient's room, in this case, the fictional patient's room. Any other observations about the Moyle anybody wants to add before we kind of begin to put this all together? One part of ABC stamp liquor, or more specifically now, because we've taken care of the ABCs, the rest of the mental status exam, stamp liquor, is the A, which stands for affect, right? So during a routine physical exam, the student has to present their mental status exam findings, including the affect of their patient, the Moyle. Affect has 5 different domains, one of which is the type of affect. That is the adjective that you feel best describes how the individual is behaving or acting, right? So this is not an area or a time to impress your attending physician with regard to your vocabulary. We keep things simple. Anybody have any thoughts about what type of affect you would report the Moyle as having?
Like I would say erratic.
Erratic, okay. Anybody else? I think, if I were presenting this patient, I'd say that his affect was anxious. The most commonly used clinical terms for type of affect include dysphoric, anxious, and irritable. Those are the 3. And those 3 actually are cover the 3 large domains of mental disorder. Dysphoric, of course, are the depressive disorders. Irritable is very nonspecific, but certainly is a word that you find in the description of the cardinal feature of mania, therefore the bipolar and related disorders. And of course, anxious affect would certainly cover now 3 chapters of the DSM. That is the anxiety disorders, and then 2 related chapters, the obsessive compulsive and related disorders, as well as the trauma and stress, trauma, it's with an A, and stressor related disorders. So those are 3 very, very common descriptors, that is types of affect. And certainly observing the Moyle, I think irritable as well as anxious would probably be at the very top of the list. That said, I do want to make a comment too. There was mention about the Moyle being agitated, and that's actually correct. In clinical medicine, the term agitated has a little bit of a different definition. Agitation in clinical medicine usually includes some aspect of motor behavior. So we often think of that in hospitalized patients as individuals who, being agitated, might pull out their IVs or continually try to get out of bed and require a lot of redirection, perhaps due to fall risk, etc. So agitation, especially in hospitalized patients, has a motor component, whereas irritability does not. So if we were to agree that this particular character, this particular fictional patient, has both anxious and or irritable affect, it certainly opens the door to discuss further aspects of his behavior, getting to ultimately rendering an opinion on his most likely diagnosis. Along these lines, remember, and it's worth restating this, these mental status exam terms are non-specific. They are not to be linked directly to a disorder. Just because we render an opinion that the individual's affect is anxious does not say that they have an anxiety disorder. Even if they have a mental disorder, it may certainly not be in the anxiety disorder spectrum. It does not have to be. So there's no specificity to these findings in the mental status exam. Nonetheless, in this case, it does appear that this character is overtly anxious and that his anxiety is clinically significant. That is, he suffers clinically significant distress and impairment when it comes to both interpersonal as well as vocational performance. Right. So at this point, the differential is quite broad, even when you just start out considering the anxiety disorders. So I'm going to take a little bit of turn here, but before I do, I want to briefly pause and ask if anyone has any questions. All right, we're good. So for this particular character, I'm kind of on the fence whether or not he demonstrates avoidance behavior. And I bring this up because avoidance behavior is a very common presenting symptom for individuals who seek help from either a psychiatrist or a psychologist. That is, the anxiety has gotten to a point where it has disrupted their everyday life. And a common example of that disruption is avoidance behavior. And when we think of avoidance behavior, a couple of ideas come to mind when it comes to diagnosis, but unfortunately, avoidance behavior is quite common and therefore non-specific, even in someone with an actual anxiety disorder. And it's worth going through this differential diagnosis because it comes up on exams all the time. And now with my clerks only about a week away from their exam, it's worth reviewing the anxiety disorders because there is a very good chance, number one, that you will see anxiety and anxiety disorders on your shelf. There's about a 100% chance there. And then there's even almost as much a chance that the questions pertaining to anxiety disorders on your shelf are going to look very, very similar. And unless you know exactly what to look for, there may be difficulty choosing that single best answer because of the overlap in symptoms that starts with avoidance behavior. So an individual, let's say a 9-year-old, maybe an 11-year-old, presents with avoidance behavior. They usually present accompanied by a primary caregiver. The answers that will often be provided from which to choose include illnesses such as separation anxiety disorder, social anxiety disorder, agoraphobia, and post-traumatic stress disorder. And choice A may be normal behavior. So there may be up to 5 potential answers. And that initial sentence in the case vignette may look very, very similar across the board, right? Presents with avoidance behavior. The next step I want my clerks to take and focus on is the actual fear. Why is it that the individual is beginning to avoid? If there is evidence that the individual is avoiding, not so much with regard to where they're going, but has issues from where they are separating from, the 2 answers that quickly come up are normal behavior and separation anxiety disorder, right? So again, you're looking for evidence that the issue is more from where they're separating from, usually leaving the home, than where they're going to, right? And then again, your differential will be that choice A, normal, and then some alternative choice, which would be separation anxiety disorder. Separation anxiety is normal. That is, it is developmentally appropriate at around 12 months of age, right? So between 6 months, 18 months is when separation anxiety peaks. The question writers for the PRIDE exam are not going to give you a 19-month-old to split hairs. they're going to give you a 9 or an 11-year-old. And this age range is certainly a red flag for you, because this condition called separation anxiety disorder was previously published in the child disorders chapter, but has since been moved into the anxiety disorders for adults, right? So the test writers are still looking at this as a child's illness. And along those lines, you are very often likely to get someone who is 9 to 11 years of age. That should be a little bit of a red flag. Developmentally inappropriate, that is beyond 18 months, right? So that's your differential. On the other hand, if the individual provides evidence that it has less to do with regard to where they're separating from, and therefore more to do where they're going, you have to investigate the question and review the question and ask, what is the fear? If the fear is of getting embarrassed upon becoming symptomatic, and symptoms can be due to anything, the single best answer is going to be agoraphobia. If the fear is the social situation itself, and performance is the most common example, we have a condition called social anxiety disorder or social phobia, right? So there's your differential. If any or all of the above has additional symptoms that includes nightmares, flashbacks, panic-like symptoms, depressive-like symptoms, whether or not evidence of trauma is provided in the question or not, you're looking at either acute stress disorder or post-traumatic stress disorder, depending on the duration, right? So that's a very quick primer on how to tackle the anxiety disorders when it comes to standardized exams. Any questions about anxiety? All that said, if we were to apply that to what we know of the Moyle, and I certainly understand there are more questions to ask, this looks like to be, that is, his anxiety looks to be due to social anxiety disorder. The actual performance itself of the circumcision might actually be the fear. And if that is the case, social anxiety disorder or social phobia would be the single best answer. Anything more on the Moyle? And if not, any other characters you'd like to discuss in last night's episode of Seinfeld, which is the Bris? What'd you think of Kramer? What's Kramer up to these days?
He's even more delusional than usual. I mean, he was talking about like these pig men, and then he said the government has been experimenting since the 50s. It was very like something you would hear from someone who's like very deluded and like believes the government's after them.
If we talk to Kramer and he demonstrates zero insight with regard to his report, and therefore we thought that this may be a fixed belief and therefore a delusion, what are the first two things that a clinician would need to investigate with regard to the etiology or origin of Kramer's delusion?
If there's a physical reason why you would be having that delusion.
Right, and physical reason usually comes in two varieties. So as a clinician, what are the two examples of a physiologic reaction resulting in his delusion?
There's substance, and I just don't remember the other one, like just a natural physical reason.
Yeah, a medical condition, exactly.
Medical condition.
Okay, so let's say for purposes of this morning's discussion that Kramer underwent a comprehensive physical examination, including blood work, and all of the above did not reveal anything that would explain Kramer's delusion. And now we're concerned that this may be the result, that is the direct physiologic effect of a substance. I think this particular episode provides us some hints, some Easter eggs with regard to what substance may be playing a role here. Now, I understand as we read the script, there is no evidence of a substance, but then again, there's a nice parallel here with medicine in that a patient's report usually will not contain a substance, but all clinicians must continue to operate with a high clinical index of suspicion nonetheless. And if you look closely at this episode, I think there's some hints that would allow us to talk about a particular substance. Number one, he reports that the quote unquote pig man is part of a government experiment. And of course, I've never asked Larry David this, but I wonder if he put that in the script for a reason. Because when you combine that with other evidence that I believe is revealed in this particular episode of the Bris, it does point to a substance. So what happens to the quote unquote pig man?
Kramer like breaks him out of the hospital and then he steals the car right at the end.
All right, so whatever is happening results in clinically significant distress or impairment, right? So we're talking about a disorder. And then there's further evidence that there was, this is the first visit now, when something happened in the hospital that brought George to hospital administration to file a complaint. What happened?
A patient committed suicide and they landed on his car.
Right? And and of course, this particular episode of The Bris, like multiple episodes in the situational comedy, certainly does bring up issues pertaining to suicide, right? So we could definitely take that direction as well with regard to suicide being a national health crisis, no doubt about that. But for the remaining time we have left, if we're going to look at a particular drug, remember the conversation between the hospital administrator and George with regard to the children's reaction that witnessed the fall. Do I remember?
She said they thought he was flying.
So put this all together. Kramer is using a substance. His behavior is clinically significant. The substance can induce delusions. And there is evidence of people falling out of windows and believing they can fly. What drug are we talking about here?
LSD?
That's LSD, yeah. Which, of course, was used in the 1960s by our government during experimentation. Now, again, we'd have to ask Larry David if this is just serendipitous, or if he actually planned this in building the script of the Bris. But in either case, it allows us to get to this drug called LSD, which is a hallucinogen. What you need to know for your exam is that hallucinogens come in 3 varieties or subtypes. There are the psychedelics, of which LSD is an example. There are the dissociatives, of which PCP and similarly structured analogs, such as ketamine, are examples. And then there are the deliriants, right? Medications or drugs that you take that can lead to acute confusion, otherwise known as delirium. So the deliriums would include anticholinergics and medications or drugs with an antihistamine side effect, deliriums, right? So those are your examples. And for the remaining 5 minutes or so of Seinfeld this morning, we're going to focus primarily on the psychedelic called LSD. Anytime you look at a vignette that focuses on a drug on a shelf exam, remember that there are both psychological / behavioral as well as physiologic effects of the drug. The psychological effects of LSD include basically all of the above. They hit the cardinal features of the major mental disorders. People who are high on LSD, who come in with acute LSD intoxication, may demonstrate the behavioral effects consistent with dysphoria or depression, irritability or mania, or psychosis. And you could even include anxiety there. So the 4 cardinal signs of the 4 major disorders: dysphoria, depression, irritability, bipolar / mania, anxiety / of course anxiety, and psychosis as well, right? So all of the above. Now there's a 5th effect. So if you're going to go with a top 5 list, the 5th effect is very important to know because number 1, there is some historical significance to this. And it's the one that usually comes up on exams that will give you a major hint that LSD or LSD intoxication is your single best answer. And that is the fear of losing one's mind, right? That comes up very often on shelf exams and other standardized examinations. And again, there's some historical significance because that in part could result in someone jumping off of a roof or jumping out of a window, the fear of losing one's mind. Individuals who ingest LSD in a therapeutic milieu with that frame of mind can find it incredibly helpful, whether microdosed, as is provided sometimes in psychotherapy, at least now in clinical trials, or even when macrodosed and resulting in an effect that is now being referred to as part of a psycho spiritual crisis, macrodosing as a new form of therapy. Okay, so in a therapeutic milieu, it can be very, very helpful. That same drug at that same dose, when provided to someone unbeknownst to them, so when it's slipped in your drink at a bar, can result in an incredibly adverse and opposite effect: the fear of losing one's mind. Right? So one's frame of mind when they ingest LSD goes a long way with regard to the type of adverse effects or not, that is adverse versus therapeutic effects that they can then experience. That is the behavioral or psychological effects of acute LSD intoxication. On the other hand, there are physiologic effects as well during the intoxication phase. And those effects look very similar to a panic attack, right? So if you see the basic physiology of panic plus very non-specific behavioral signs, anxiety, depression, but fear of losing one's mind, acute LSD intoxication is likely your single best answer. The other thing I want to just briefly mention about LSD is that it does not, and this goes for all hallucinogens, LSD, PCP, ketamine, deliriums, do not have any identified withdrawal phase, right? Intoxication on the exam only, LSD withdrawal, similar to PCP withdrawal, ketamine withdrawal, right now on board exams does not exist. So that's Kramer's subplot. We have about a minute left in our discussion. Any final thoughts with regard to the episode we're discussing this morning, Seinfeld, the Bris? All right, then we'll leave it here. Clerks, I will see you in about a half an hour. Others, we will be back live 12:30 for Night's Watch. Thank you.